Welcome to JACC This Week, your fast and focused briefing on what's new and what matters in cardiovascular science, straight from the pages of JACC. I'm Harlan Krumholz, Editor-in-Chief of JACC, and in this week's focus issue on heart failure in practice, we explore how far we've come in turning evidence into impact for patients with HFpEF, HF-improved EF, genetic cardiomyopathies, and more. We looked how foundational therapies perform, what happens when they're withdrawn, how risk is still misunderstood in key population, and what tools we might need to make the next leap forward. So let's get started. The first paper is a Sogaldi-PEF, dual therapy in HFpEF and in heart failure moderately reduced EF. So why does it matter? Well, this paper addresses that the SGLT2 inhibitors are now foundational in HFpEF and in heart failure with moderate EF reductions. But there's been no prior randomized trial directly comparing SGLT2 inhibitor monotherapy to SGLT2 inhibitors plus MRA. The Sogaldi-PEF trial fills that gap. Ferrer and colleagues conducted the first randomized study designed to compare dapagliflozin plus spironolactone versus DAPA alone, using a crossover design in patients with heart failure with moderately reduced EF or in HFpEF. The primary outcome, change in NT-proBNP, showed an 11% greater reduction with the combination. These data provide mechanistic and clinical insights in a population often underrepresented in large trials, older patients with common comorbidities like AF, CKD, and diabetes. However, a few notes of caution. NT-proBNP reductions, while often associated with better outcomes, do not always predict success in phase 3 trials. The ARNI experience in HFpEF is a case in point. Moreover, and in addition, the combination therapy in this study led to larger eGFR decline than either agent alone. The eGFR drop with DAPA was about 3.3 milliliters per minute per 1.73 meters squared, with spironolactone 5.8, and with both nearly 10, suggesting the effects are additive. The frequency of greater than 30% or greater than 40% eGFR decline was also higher with dual therapy. These findings underscore the need for close monitoring. Again, this may be what an early change is, and this was a relatively short study, so it's going to be important to follow this over time. The authors say, quote, "The results can better inform future trial design and patient selection for studies using SGLT2 inhibitor MRA combinations compared to SGLT2 inhibitors alone." The editorialists emphasize, quote, "Aligning treatment to absolute risk, minimizing therapeutic inertia, and addressing polypharmacy through high-value prescribing are now central to clinical care." The next study, Guideline Therapy and Outcomes in Heart Failure with Improved EF. Why it matters. In 2022, ACC/AHA guidelines introduced a new classification, heart failure with improved ejection fraction, defined as left ventricular ejection fraction rising from greater than or equal to 40 to over 40. But how often does this occur? And how should we treat these patients? All are still open questions. Min and colleagues analyzed 24,000 plus patients with new HFrEF in Kaiser Permanente. About 31% improved their ejection fraction within a year. These patients were generally younger with fewer comorbidities. Compared with those with persistent HFrEF, those with heart failure with improved ejection fraction had about half the mortality rate, 5.7 versus 11 per 100 person years, and fewer hospitalizations, 30 versus 42 per 100 person years. But that improvement came with a risk. Use of GDMT declined over time. Withdrawal of therapy at 6 months was associated with an increased risk of worsening heart failure events or death. The message of this was that heart failure with improved ejection fraction does not equal full remission or cure. This study suggests that therapies should be maintained. But it also suggests that we really need prospective trials in this group. And they say, quote, "Prospective trials in heart failure should enroll patients with heart failure with improved EF to better understand whether incremental pharmacotherapy may provide additional risk reduction." So right now we have really the observational studies supporting this idea that GDMP should continue, but we need to learn more. In their editorial, Perry and Stevenson reflect, quote, "The journey to improvement will hopefully include new lanes as GDMTs continue to evolve beyond traditional triple therapy. Yes, it's going to get more complicated as we have more options. And now we've identified this group that improves, So no longer is really singularly HFrEF or HFpEF, but is sort of somewhere in the middle. We also had some interesting brief reports. There was something from Fine Arts HF. What happens when you stop finerenone? Well, here's why it matters. Fine Arts HF demonstrated that the nonsteroidal MRA finerenone reduces cardiovascular events in HFpEF patients. But what happens if you stop it? The authors used a protocolized, blinded withdrawal phase to answer this question. Among patients who had been randomized to finerenone, short-term withdrawal was associated with a significant rise in cardiovascular adverse events compared with those who had received placebo. Most events were heart failure related and occurred within 30 days. These findings reinforce the sustained benefit of long-term MRA use and caution against de-escalation without strong rationale. The authors write, quote, long-term treatment with finerenone resulted in sustained reductions in cardiovascular events and a persistent clinical benefit even after years of treatment. In another brief report, the authors look at sex differences in genetic dilated cardiomyopathy. Here's a question. Are women and men with the same pathogenic gene variant equally at risk? Mangino and colleagues studied 90 patients with dilated cardiomyopathy and pathogenic variants and found that deleterious variants in the desmoplakin gene were significantly more common and more prognostic in women. Female carriers carried a higher risk of adverse events than men. No sex-based differences were found in other genes, such as TTN or LMNA. The results underscore that sex may modify genetic risk and should be considered in diagnostic and care planning. In another study, LMNA cardiomyopathy and stroke risk in AF. LMNA-related cardiomyopathy is a genetic form of dilated cardiomyopathy marked by early onset arrhythmias, conduction disease, and high thromboembolic risk. The authors analyzed patients with AF and pathogenic variants, those with LMNA and with TTN truncating variants as controls. All systemic embolic events occurred in the LMNA patients, and all during brief interruptions in anticoagulation, despite low CHADS-VAS scores. TTN carriers had no events during this study. The findings highlight how conventional risk tools can fail to capture true embolic risk in LMNA cardiomyopathy. For these patients, uninterrupted anticoagulation may be essential. This issue also has some pertinent reviews. In one, the topic was rethinking ICD use in heart failure. ICDs remain a cornerstone for sudden cardiac death prevention in HFrEF, but are we targeting the right patients? That's what this review asked. Wallace and colleagues argue that the guideline thresholds based on left ventricular ejection fraction are no longer optimal. While sudden cardiac death rates have dropped among patients with HFrEF on modern therapy, those with HFpEF continue to experience high sudden cardiac death risk, yet are not considered for ICDs. The review lays out a framework for future use of individualized dynamic risk models built on AI and diagnostic testing, which could transform how we identify those who would benefit most from ICDs. Quote, the use of AI to extract and process test results and machine learning to generate risk prediction models provides a promising new direction. In another review, aldosterone and cardiokidney disease, the authors walk through the multifaceted effects of aldosterone across both the heart and kidneys, genomic and non-genomic, MR-dependent and MR-independent. They examine steroidal and non-steroidal MRAs, partial MR agonists, and aldosterone synthase inhibitors as current and future therapies. The review reinforces aldosterone as a central target in heart failure and CKD. We also have some reviews from JACC Heart Failure. Failure to launch, why proven heart failure strategies don't scale. In this review, they address the topic that despite proven effectiveness in trials, many implementation strategies, such as virtual care teams, audit feedback systems, and rapid medication titration protocols, have failed to gain traction. They explore the barriers and often strategies to better translate evidence into routine care. In another review on digital heart failure optimization, DeVore et al. Evaluate digital tools designed to initiate and titrate heart failure medications outside traditional visits. These technologies show early promise, but more evidence is needed on their long-term effectiveness, sustainability, and impact on disparities. Finally, there's a review on heart failure and improved EF management. This is very relevant given the Kaiser study. The authors argue that heart failure with improved EF is a heterogeneous condition. They explore how to better risk stratify these patients and identify a subset in whom partial de-escalation of therapy might be safe, but emphasized that we need better tools to support these decisions. So what did we learn in this issue? Sogaldi-Pef begins to fill a key evidence gap by comparing SGLT2 inhibitor monotherapy with SGLT2 inhibitor plus MRA, showing incremental NT-proBNP benefit, but also a higher risk and additive eGFR decline. In heart failure with improved EF, therapy often declines after EF improves, but guidelines say to continue. In this study, we learned that outcomes and event rates can support that recommendation in an observational study from Kaiser. Third, finerenone withdrawal may quickly reverse benefits. FINE-ARTS-HF shows continued therapy matters. Next, we learned that women with DSP variants may face disproportional risk in dilated cardiomyopathy. Sex-specific insights are clinically relevant. In another brief report, we learned that LMNA cardiomyopathy dramatically elevates embolic risk, beyond what risk scores can predict. And finally, in a review, it was suggested that ICD criteria may be outdated, and we need dynamic models that reflect individual risk. I hope you found this issue educational and useful. Thanks for joining me on JACC this week. Until next time, stay curious.